Good evening, dear colleagues. I'm Dr. Dima from Romania, and my topic for today is bone splitting. Searching the literature, I have seen that in early 70s, Dr. Tatum started to use D-shaped graduated osteotomes and tapered channel formers to insert implants and to increase the bone volume in the same time. And he placed more than 5,000 implants between 1970 and 1985, expanding the bone with more than 3 millimeters, with very good results and stability in time. In 1992, Massimo Simeone described this surgical technique as a longitudinal alveolar ridge splitting in two parts, provoking a green stitch fracture using small scissors. And in 1994, Summers and Scipioni reviewed and published articles on edentulous ridge expansion with more than 98% of the implant survival rate for over 5 years. That means that this is a predictable technique. But talking about bone augmentation, actually we are talking about implant insertion. And we have to know what requirements do we need for this technique to be a long-term result, And we need minimal horizontal bone width of 3.5 or 4 millimeters. We need minimal vertical bone height of 10 millimeters. We need to have no concavities in the alveolar bone profile. And very important, the horizontal osteotomies have to end at least 1 millimeter before neighboring teeth, or maybe 1.5. Talking about bone augmentation, we are talking about bone implants and implant success. And we can see here that we have to keep in mind some aspects about implant success. We have to keep in mind the soft tissue, and we all know that nowadays the bone set the tone, but the tissue is the issue. That's why we have to keep in mind also the biotype, which is very important. And you will see that talking about bone augmentation, I cannot not talk about the soft tissue. And every case I will show you, it's about bone augmentation and soft tissue augmentation in the same time. And of course, it's also important to talk about implant positioning, which is very important to be in ideal position from the prosthetic point of view. We have to talk about periodontal aspects and also emergency profile, because using prosthetics correctly, we can increase our results, and using the prosthetics incorrectly, we can destroy everything. So I would recommend you, before making any incision, to keep in mind that you have to think about the gingival biotype, the buccal bone, and interproximal height of the bone. Why? Because if we have a gingival biotype thick, we have a smaller remodulation, and if we have thinner biotype, the remodulation will be bigger. If we insert the blade into the sulcus and the buccal bone is class 3, we will generate gingival recession. So the patient could come with one problem and go home with 3 problems. And of course, the interproximal height of the bone is very important. If we cut the papilla and the interproximal height of the bone is class 3, we destroy it forever. So nobody could rebuild it. So just keep this in mind before starting, and keep in mind that the most important thing before the treatment is to start with the end in mind. Otherwise, the road could be too long if we don't know the destination. And this is my favorite slide before starting the clinical cases. So now let's see the clinical cases. The first case is about crest splitting without vertical incisions, because we have two options: to make or not to make the vertical incisions, and we'll cover both aspects later on. This patient is a young girl, 32 years old. She has an old bridge, like you can see on the X-ray, and she wanted to remove it and to have a modern treatment with dental implants. After removing the prosthesis, we can see the horizontal bone defect, and we have to think about the treatment plan. We have to define every detail before starting, and I recommend you to take your time to make the treatment plan correctly, because sometimes making the treatment plan is even more important than the treatment itself. In this very particular case, I have decided to use a full flap, as you can see later on. But before raising the flap, we have to keep in mind these 5 points. 1, 2, 3, 4 are about the incision inside the sulcus and cutting the papilla, as I told you before. And number 5 gives us important information about the height of the keratinized gingiva. And these informations are very important to know how to insert, how deep to insert the implant according to biological width, because it's very important to keep in mind the biology. Otherwise, we will have bone resorption, not bone remodelation, like Thomas Linkevičius said in his zero bone loss concept. That means that if we know how biologically the bone will react, we know if the bone will be at the level of the implant or it will be lower. So we have to keep in mind every detail to end up with good results. After that, we can raise the flap. We can see that the width of the bone is not enough for a normal surgical procedure, so we need here bone splitting. The first step is to cut the bone in 2 parts, and I'm using the piezosurgery for this step. And then we just need the pilot drill. I don't use any other drills from the surgical kit. We just need the pilot drill, and then the third step is to use the bone expanders. And we have a very good kit from MIS, as you see in the picture, using to expand the bone. We can notice also a vertical bone defect, and we want to treat this in the same time. Actually, I'm trying to do the best for my patient, and I make the treatment plan for the patient like I would be the patient. And if I would be the patient, I would like to have only one surgery and to fix every problem in only one session. Of course, if this is possible. And we will see if it's possible or not. We can see also the horizontal bone defect, and look at the bone, at the buccal bone. If we would use in this kind of situation the drills from the kit, for sure we will destroy this buccal bone. And I know that some people will say, okay, we can make GBR. But what is better, to have the natural bone connected with the vessels and 100% natural and vascularized, or to harvest the bone from another area and to give to the patient one more wound, and of course the feeling that the surgery is a little bit too much. For sure, if I would be the patient, I would take this kind of surgery with only one wound, and then we can insert the implants like you see in this picture. And you can see that I just compacted the bone and I didn't destroy the buccal bone. The buccal bone is intact, and we can see later on the results. Every time I'm using this procedure, I combine it with GBR, because we know that after raising a flap, the bone will suffer and we will have remodelation. And we never know how big this remodelation will be. That's why I like to be very predictable, and I like to be very safe, so I'm using GBR to protect the buccal bone and to have a long-term stability of this area. In this particular case, I have used one resorbable membrane like O6+, and you'll see the advantages. The suture must be free of tension, and this is one of the 4 steps of past principle described by Homley Wang in 2006, and this is about the perfect closure without any tension for having good results when we are making GBR. We can see the picture immediately post-OP, and we can see it at 10 days post-OP, and then at 20 days post-OP. So we have transformed this concavity in convexity. And I think it's very important to have no concavities when we are talking about aesthetics. And I started many years ago to consider that the lateral zone is an aesthetic zone too. Because sometimes the patients say it's okay, but after going home and looking a little bit closer, they said, okay, why do I have this gray area around the crown? Around the crown, maybe you have some similar cases. And then I started to think about aesthetic zone at entire mouth. Why is so important to have no concavities? Because concavities gives us two big disadvantages. The first one is that any concavity leads to gray shadow. It doesn't reflect the light. And the second one is food retention. And if we have food retention around our crowns on implants, for sure, we increase the risk of peri-implantitis in the future, and we don't want that. So keep in mind to transform every concavity in convexity. After 6 months, we uncover the implants and we can see how beautiful the membrane looks like. It's still there, it's still intact, so it supports us with a good volume for a good result. But sometimes we can increase the bone volume, but we cannot increase from the first time the gingival contour. That's why I decided to make a roll slab in the same session with inserting the healing abutments to increase the shape to have at the end convexities around the crowns. And the first step is deepitalization, and then we can roll it inside. But first of all, we can see the result of horizontal bone augmentation, and we can see also the result of vertical bone augmentation, because you know that there was a vertical defect around the second implant. After we put the healing abutments in place, we roll the flap inside. We need to protect the membrane, and I have used also a collagen sponge as a space maintainer too, not to let soft tissue to collapse between the two healing abutments. And then I just made the suture, put the provisional in place, and then we can see the final result. And we can see that we started with this concavity and end up with these convexities around crowns. And we can see also on the X-ray that we have a good tissue around the implants, we have a stable bone. And we have good results when the results are also the same in time, not only in a few months after surgeries. So we can see the results in time. We can see on the X-ray the stability of the bone. And we can see also after 1 year that the soft tissue looks even better, and we cannot see that there are implants there like we can see sometimes with that gray shadow around the crowns or on implants. This case was more about bone compression. Now let's see how we can expand the bone a little bit more, not only to compress it but to expand it. And the case starts like this, with an old bridge, and we have to remove that bridge and to treat the lateral upper left side, as you can see on the X-ray. We can check on the CBCT, and it's very important to check the quality and quantity of the bone on CBCT, like you can see here, to decide if this is a proper case for bone augmentation with bone splitting, or is better to do only GBR, because we need the bone to be elastic. Otherwise, if the bone is too rigid, we can fracture it, and you'll see some cases on the mandible where the bone is a little bit more rigid. In this particular case, we started with the width of the bone around 3.54 millimeters, so ideal case for bone splitting, and one density around D2, D3, which is very good to use it on bone splitting. We started with a full slab, and we can see that the bone looks like narrow, And of course, the first step is horizontal bone cutting with a tip from our piezosurgery kit. And we see how nice we can make this line between the buccal area and the lingual area to separate two parts for expanding them later. But what is very important is that we have to cut the horizontal and vertical deeper than 8 millimeters. This is very, very important, otherwise we can fracture the bone. And the osteotomies have to end at least 1 millimeter before neighboring teeth. Also very important, otherwise we can provoke necrosis and have a lot of problems. And then it's time for bone expanders. And we use bone expanders after we just use the pilot drill and no other drills from the kit to conserve the bone as much as possible. And the sequence is very important too. So we just put in place the bone expander for the first implant, then we started the osteotomy for the second one, as you can see in the picture, and then we insert the second bone expander. What is very important here is that we have to keep in mind that we don't have the drills to give the direction for the implants. We will give the direction for implants with these bone expanders. So it's very important to insert them in ideal position from the prosthetic point of view, to insert them parallel to have at the end the implants in the ideal position. And after that we can see how nice the bone it will expand. And then it's time for the third implant. Like you can see here, we keep the bone expanders in place so that we can make the osteotomy parallel to the other two. After that, we start implants insertion with the area where we have the bone, the width of the bone, the bigger. Because otherwise, if we compress it too much from the beginning in the area where we don't have enough bone, we can fracture it. So we start it step by step from the distal to mesial, like you can see here. Then we insert the second implant, like you can see here. And we can see after implant insertion how we can expand the bone, and we didn't lose any millimeter of buccal bone. And now it's time to insert the third implant. And after inserting the third implant, we gain the volume with more than 4 millimeters without losing any bone. So this is very important. After that, of course, I'm using GBR because I like to be very safe in time. And it's very important to close it properly. And almost every time I try to increase also the soft tissue, as I told you. In this particular case, I decided to use a palatal split flap to cover the area of bone augmentation. And we can see here how I did it. I just try in here if it's enough, and then suture it from the palatal to buccal to cover the area, and then cover everything with a membrane and close it without any tension. And we can see after 2 weeks and after 4 weeks the healing is good, and you can see the increasing of the volume. Now we have very weak crest, so we can hope for a very nice restoration at the end. And we can see on the X-ray also the ideal position of the implants and the bone volume around implants on the CT sections. The third case is about crest splitting with vertical incisions. And sometimes we need this kind of vertical incisions because otherwise the risk of fracture is too high. And we will see why. Seeing the CBCT sections, we can notice that the case is very difficult because we started with 3.3, 3.4 and only 10 millimeters height of the bone. So this is close to the lowest value we can start this kind of technique. Clinical pictures looking like this, and we decided to make a full flap, and then of course starting with bone splitting combined with GBR. But as I told you, this time we need something more. And we can notice the horizontal bone defect, but we can notice something different than the first cases. We can notice this concavity. And we know that when we have concavities on the buccal area, this would be very difficult because we have already a line of fracture there. And we have to try to avoid a fracture. And I have started more than 14 years ago using this technique, and I tell you that I didn't fracture any buccal plate. I mean fracturing with taking out, not having just fissures. Of course, we can have fissures, and you will see in these cases, but not fracture, not to keep it in place vitally. So coming back to this case, we need some vertical incisions because of this concavity, which leads to fracture for sure if we don't use these vertical cuts, like you can see here. And of course, we do these vertical bone cuts with piezo. I think is the best way for our patients, and if the patients are satisfied, for sure we are satisfied. And then, as you can see on the picture, we can use the pilot drill and we can have the same steps. But don't forget that we have to keep in mind these 8 millimeters about horizontal and vertical cuts must be deeper than 8 millimeters, or at least 8 millimeters, otherwise you can fracture the bone. So this is a sensitive technique, but if you use it correctly, it's not so sensitive. It's very, very predictable. And let's see how it works. The third step is to use the pilot drill, as you can see on the picture. And of course, we have to keep in mind that the osteotomies have to end at least 1 millimeter before neighboring teeth. I repeat this because it's very, very important. And there are some criteria which, if we respect them, we have good and safe results. Otherwise, we can have problems. After using the pilot drill, we start with the bone expanders. And if the bone is D2, D3, we can expand it a lot. And you will see how. You can see now, after screwing the expanders, that the bone started to expand. And don't forget to keep them parallel and to keep them in an ideal prosthetic position to have a good result at the end. And then we can insert the implants. And the stabilization is very important here too. We just keep one of the expanders in place and insert the other implant after we take out the other expander. But what is important is to insert the implant very gently and very slowly. Otherwise, we can fracture the bone. And you can see here, after inserting the implant very gently, that we can increase the bone volume even in a situation which was not so easy. We can increase the bone with more than 3 millimeters. And look at the buccal bone. The buccal bone is intact, so we kept it like more than 2 millimeters for a safe result. And of course, we have to take care of this concavity between two implants. Even if we don't have an implant there, if we want a good prosthetic there, we have to transform this big concavity in convexity. And we will do this using GBR also. So let's see. And sometimes it's very important when you insert the implant, if you see that the bone it's almost to fracture, just unscrew it and wait a little bit. Give time to the bone to relax a little bit and then insert it again very slowly and very gently. So now it's time for GBR. We transform this concavity and convexity using bone augmentation with resorbable membrane and xenograft in this particular case to have a more stable result in time. And what is also very important, this kind of the tension-free suture. So we can see that we have no tension in our flap, and this is very important for bone regeneration. And you can see that this area was also transformed from concave in convex. We started with that big concavity and ended up with this convexity. And now it's time for prosthetics. Prosthetics could help us a lot or could destroy the surgical result. And now I have used one convex pontic to shape the gingiva. Even if we don't have 3 implants, we have 2. We have this advantage that we can reshape the gingival contour and we can reshape the papilla between the crowns better when we have a pontic than when we have 3 implants. We can also notice that we have respected the biological width when I have inserted the implants, so for sure we have a safe and long-term result. And this is very important when we check the tissue, the soft tissue around the implants, to have a thick, keratinized and attached gingiva. Otherwise, we can have problems in time, and of course we can have peri-implantitis. So we can see after 1 year that the bone is stable, and every time when we have keep in mind the biology and we have good tissue around crowns, the bone will be stable. And we can see that respecting the biological width, the convex pontic, 3D ideal position, and a good prosthetic, we can recreate the papilla and we can have a safe result in time. Like you can see here at 1 year follow-up, that it looks natural. We don't see that we have implants. We don't see any difference between the crowns on teeth and the crowns on implants. The last case is a little bit more complicated and is at the mandible. And they started thinking that periosteum is the best membrane in the world. And searching the literature, we can see that we have one option like periosteal pocket flap described by Marius Steinman and Maurice Salama. And this technique is about starting with a full flap, and after we are at the mucogingival margin, we just prepare a split flap, and then we can detach the mucosa and use the periosteum, making a pocket where we can insert the augmentation material. But the difference is that when we have this kind of approach, the periosteum will be a little bit lower than the crest. And in this particular case, first of all, we have to decide if bone splitting is good for this bone quality and quantity, and if we need or we don't need the vertical cuts. And we see here that the width of the crest is about 4.3, 3.9 millimeters, so it's ideal for bone splitting, and we can see that it's ideal for bone splitting having the corticals not too strong, and between them we have very good tissue, hard tissue to expand. Because sometimes at the mandible the cortical plates are too strong and it's very difficult to expand them, so we need vertical cuts, but sometimes even with the vertical cuts it's very hard to do it. So first of all, don't start without having a CBCT and without keeping in mind all these details about the bone and about the bone density and how we can expand it or not to decide if it's a proper case for bone splitting. Coming back to this case, we can see after removing the prosthetics that the patient had a bone defect between the teeth, and we decided to start with bone splitting, but in this particular case we decided to use this technique, periosteal membrane technique, described by me more than 1 year ago, after thinking that periosteal pocket flap is a very, very good technique, but is not enough. And the difference between periosteal pocket flap and periosteal membrane technique is that we started with a split flap from the crest. And we know that many years ago this was impossible because we didn't have the bendable blades. But now, having bendable blades, we can start with split flap from the crest. And the advantage is that we can make the periosteum section on the lingual, so that after we put the augmentation material on the buccal side, the periosteum will be at the same level with the crest, not lower. And I will show you the clinical pictures. So, starting with split flap from the crest, this is not easy, and we have to keep in mind that every technique must be applied on the proper case. And of course, for bone splitting and for this technique and for every technique which is a little bit more sensitive, we have to choose the best patient for that technique. In this case, the tissue was perfect for having this kind of technique because it was thick on the crest, so we can prepare a split flap on the crest and then just to section the periosteum on the lingual, as you will see later on. So after preparing the split flap, you can see the split flap on buccal and also on lingual side. Be attentive, we can do this kind of approach only if the soft tissue is thick on the lingual side too, where we know that many times it's very, very thin. If it's very, very thin, don't try to do it because you can perforate the soft tissue and you can provoke necrosis. So this kind of technique is a little bit more sensitive and we have to apply it only when we have a thicker tissue on the lingual part too. After that, we can see the 4 parts now: periosteum, buccal and lingual, and mucosal detachment, buccal and lingual. And then we can start with the bone splitting like in a standard case. First step, just separating the bone in 2 parts, one lingual and one buccal. And in this particular case, we didn't need any vertical incisions because checking the CBCT details, we have seen that the bone could be expanded without these vertical incisions. So I have started with the expanders. Don't forget to keep in mind that they will give you the final position of the implants, so you have to insert them from the very beginning in the ideal position. And after that, we can insert the implants. And we can see here that we have expanded the bone with more than 3 millimeters at the mandible without any vertical incisions. So this is possible, but it's possible if we take the proper case. Don't forget about this. We have to choose the proper case for the proper technique, or the proper technique for the proper case. Otherwise, we can have problems. And of course, that CBCT helps us a lot, and I think is the most important thing to start searching the details on the CBCT, and after that to decide the technique. We can see here how we have expanded the 2 plates, and now it's time for bone augmentation. And we can see that I have filled the space between the 2 plates with bone augmentation material, but also I have filled this area between the buccal plate and the periosteum, because we know that this is the most sensitive part, and usually the bone will resolve on the buccal plate. That's why I prefer every time to have one more step to be very safe, and this step is guided bone regeneration combining with bone splitting. And after that, we can see that we can suture the periosteum. This is the big advantage of this technique, that we can suture the periosteum just above the crest. So we can cover all the volume at the of the bone augmentation with the periosteum, comparing with the periosteal pocket flap, where we have the periosteum a little bit lower than the crest. So we have just a small part, but maybe the most important part of bone augmentation uncovered by the periosteum. And I tried a lot of cases with this technique, and I realized that the periosteum could work maybe better than any other membrane. And why? Because it's 100% natural, it's very stable. We have it very stable. We just have to suture it at the crestal part, and it will be very stable for the granules, for bone augmentation, and is also vascularized. And of course, it's 100% natural, and it's free. So a very good and rare combination. And after that, the tension-free suture is very important to have safe and stable result. Otherwise, if we have dehiscence, the literature said that we can lose from 60 to 20% of the result. So if we end up with 60%, of course it's okay, but if we end up with only 20%, this is the difference between being successful and not. So, checking again where we have started, and we can see after bone splitting and GBR that we increased with more than 2.3 millimeters the buccal bone, and this is very stable after 6 months. When we uncovered the implants and we inserted the healing caps. What is very important when we insert the healing caps is that we have to try not to take out the periosteum from the bone, because every time when we take out the periosteum out of the bone, we generate some more bone remodulation. So it's good if we can make a split flap to let the bone covered by periosteum and to insert the healing caps very, very gently. And we can see that we have respected again the biological width, and we generated soft tissue, quality soft tissue around the implants. And that means that we have keratinized, thick, and attached. Very important also to be attached keratinized tissue around our implants for long-term results. So after that, it's time for prosthetics and for impressions. We see the position of the implants in ideal position from the prosthetic point of view, and this is very important for the long-term result. Otherwise, if the implants are not in the ideal position, we know that it will be remodulating time more. And then of course it's time for the final crowns and final prosthetics. So we can see that we started with this concavity and then end up with a convexity around our crowns. And of course we transformed again the concavities into convexity, and we talked a little bit earlier about the reasons for this approach. Which are the bone splitting advantages? Do we have any advantages? Of course, when we want to decide if we are going to use or we are not going to use a technique, we have to know why. Do we have any advantages or no? Because if you don't have advantages, of course, we don't need this technique. But I think we have a lot of advantages. First of all, is a minimally invasive procedure. We don't need to harvest autologous bone from another area to have another wound, and the patient will be very happy having only one wound, not two or maybe three. The second one is that it conserves the bone around the implants, which is very, very important. Otherwise, if we use all the drills from the kit, we can destroy the buccal bone. And of course, we can regenerate it. But what is more predictable? To have from the very beginning the bone around the implant, the patient's bone around the implant, or to try to reconstruct it. For sure, the first option is better. It shortens the treatment because we can insert the implants in the same session with bone augmentation, having only 4 millimeters, 5 millimeters of bone, which is not possible if we use the normal procedure and we destroy the bone drilling it. Of course, we can do it in the same session, having guided bone regeneration, but with more efforts and not so predictable. It increases bone density around implants, and this is very important when we are talking about D3, D4 density. And maybe the most important thing, we have 1.5-2 millimeters of autologous buccal bone, vital and vascularized in contact with the implant. And I think this is the goal of this technique. Take-home message. Keep in mind that horizontal and vertical cuts must be deeper than 8 millimeters, otherwise you can fracture the buccal bone. Keep in mind that the osteotomies have to end at least 1 millimeter before neighboring teeth, very important, otherwise you can provoke necrosis at that area and having a lot of problems and, of course, aesthetics problems. And implant insertion should be done slowly and with care. And if you feel that when you're inserting the implant, the bone is already almost to be fractured, just unscrew it and wait a little bit. And one more tip, you can press with one instrument on the buccal bone so that you cannot let the buccal bone to be compressed too much. In this way you can put the pressure on the palatal side too, not only on the buccal side. Because of course the forces are trying to go where it's easier to go, and normally it's easier to go on buccal bone, not on the palatal bone. Steve Jobs said that the only way to do great work is to love what you do. And I'm sure that you are here this evening because you love what you do. And I'm sure that you are here because you know that in our profession, being just good is not good enough. So all I want to say now is dream high and happy patience for all of you. Thank you very much for joining me this evening. Thank you. Now I'm ready for the questions and I'm going to read them, and after that I hope we have time to answer to everybody. Okay. First of all, thank you very much for your very nice words. And now let's try to answer to every questions, even if there are so many questions. So the first one, Dr. David Diamond. Is it impractical to do ridge split for only one tooth side? Is it better to do ridge augmentation instead? It depends. I have done some cases for only one tooth, but only maxilla. It's very difficult to do it at the mandible because you don't have hard tissue enough to expand, and being a little bit harder, you cannot expand it, so it's not so good. But at the maxilla, having D2 or D3, you can expand it even if it's the treatment is for only one tooth. Okay, another question. Tell me the parameters to avoid bone splitting when it's too risky. The bone splitting is too risky when you have the cortical plates too strong and between them the trabecular area is too thin. Because otherwise, if you try just to enlarge a very strong area, you will fracture it. So first of all, you have to check the CBCT sections, and if you see that the the cortical plates are too strong, more than 2-3 millimeters sometimes, because we know that sometimes we have a lot of cortical bone and not sponges between two plates, it's better not to do it. And be attentive that this kind of situation is also a problem for guided bone regeneration. If you try to make some osteotomies in the bone and they are not bleeding, don't continue. And Daniel Buzier said that if I saw the bone white without any bleeding, I stopped the surgery. I didn't try to make the GBR because I know that will not work. Okay. Another questions. Dr. Assistant Lecturer Mustafa, how to ensure ideal implant position and that implant not to buckle during splitting? Yes, this is a very good question because as I told you, the easier way is to go to buckle for the implants and also for the first step when we are using expanders. That's why you have to keep the pressure to the palatal side. When you make the osteotomy and you insert the bone expanders, just press them to the palatal side. Don't let them to go to buckle. Because otherwise, if you just let them to go where they will want on the buckle because it's the easiest way, and we already take the easiest way, and it seems that the tools takes the easiest way too. Another question. Can you use carbide burrs for the osteotomy? Yes, we can use, but you lose bone, and the idea of this technique is not to lose bone. So I think the best way is to use the piezosurgery. Excellent, thank you very much. Have you ever tried osteotomy to split open the bone? No, I never tried. I hate to hit the patient with a hammer and to use osteotomes. That's why I didn't buy a hammer, because when I have a patient and he had a treatment and the doctor treated him with a hammer, he talks about this like a very unpleasant part of his life. So I will never use a hammer on my patients. Thank you first of all, Mr. Etigula Kiazi. Any suggestions to achieve tension-free sutures? Oh, we have to, sorry, but I cannot answer in only one sentence for this question. To have tension-free suture, we need to talk one day. We have courses, one-day courses for soft tissue management. So I'm sorry, but it's impossible to answer in only one question, in only one sentence. Excellent presentation, thanks a lot, excellence, okay, thank you. So thank you very much, it was a pleasure to be here with you, and I hope it will be helpful for you, and from the next day you will improve your work and you will make your patients happy. Thank you very much.